It is a huge honor today to be podcast interviewing Carla Cohn, who graduated in 1991. And I have to tell you, not to be offensive or anything, but you like working on children. And a lot of us older guys, the one thing we don't want to do is work on kids. I mean, I love root canals, extractions, but you love working on kids. How did that happen?
I hear you. Well, thank you for podcasting with me. It's a great honor to podcast with you. How did that happen? It happened like many things in my life. I got onto a path of maybe not exactly my choice, but my destiny, let's call it. And I did a year's internship at Children's Hospital right after dental school.
In Winnipeg, Manitoba, Canada.
You bet. And great mentor, Howard Cross, fantastic dentist. And so I did that, and after I left that internship, I went and I did a couple years of general practice dentistry. And it didn't take me too long to realize that the adults were not a lot of fun, but the kids were. So I was fortunate enough to be able to be in a practice and in a position where I could just limit my practice to seeing kids, which is what I love to do, and I never looked back.
You know, so you're not a specialist. You're a general dentist who limits their practice to children.
Absolutely.
So does the whole practice only do children, or just you do only children in your practice?
Good question. So I'm in a large practice. I'm in a group practice. We've got about 14 dentists, and there are 3 dentists that I work with over on my side of the clinic, which is called Kids Dental, and we only see kids there. We have an orthodontist that comes in and does the ortho thing for us. So that's become our niche, and let me tell you, it is something that is definitely necessary because, as you know, there are maybe 200,000 and change general dentists, and out of that we got about 6,000 and so pediatric dentists. So there is no way that all of the pediatric dentists can service all of the kids that need to have help. Most of the kids that are being seen for care are being seen in general practice offices. So it's a great thing to be able to offer these kids a service that they need and to offer it well and to do it well.
And I also think that one of the things a lot of general dentists don't think about is that some of the greatest endodontists in the world never went to endo school. They just said, I'm going to limit my practice endo. I'm John McSpadden in Chattanooga, Tennessee. We have Ben Johnson in Tulsa, Oklahoma that started Tulsa Dental Products. And in my years, I've seen many dentists who were in a small town of like, say, 6 or 8 dentists, and they only wanted to see the children, or they only wanted to do the endo, and they went to all their friends and say, I will limit my practice to just endo, and I won't do the crown or the extraction or have hygienists. And they just didn't go to endo school. And a lot of endodontists say, well, that's not right. You should go to endo school. And it's like, well, these guys have done more endo than anyone who ever got out of endo school.
Yeah.
So you got out in 91, and this is 2015, so I'm sure you've treated 5 times as many children as anyone who ever graduated with a pediatric dental residency.
I've seen a lot of kids, and I've seen a lot of things, and you know it's important to keep up on what's current and literature, but it's really important to see your kids and to see them well. Treat your kids like you'd want to be treated, or like you want your own children to be treated. So that's what we go for and do the very best that we can.
So what's hot and what's not in pediatric dentistry?
Well, I would say there's a few things that are hot and up and coming. If I had to pick a few to talk about, because we only have a limited amount of time here, I would have to say that the most advanced in pediatric dentistry are zirconia crowns. So you've been using zirconia crowns in general dentistry for a lot longer than we have. But about 5 years ago, zirconia crowns came on the scene in a very strong way. So we have prefabricated zirconia crowns, pre-sized, so like as if you would find your stainless steel crown kits. We have zirconia crowns that are sized in a similar fashion. And we can offer our kids aesthetic full coverage restorations, which is huge. Back in the in the day when I was doing my internship, and we would see a lot of decay, and we still see a lot of decay, but anterior decay on kids' primary teeth, we didn't have a lot of options. We saw those 4 anterior teeth decayed. We used to call them 4 little ugly ones, and take the kid down to the quiet room, and it wasn't very quiet, and we'd need to remove these 4 anterior teeth. And now, if these teeth are salvageable, we don't have infection, we just have some decay that can be fixed, we can save these teeth for these kids in the anterior. Is a huge thing, because it helps these kids to develop confidence. It helps them to be able to smile. It helps them with their speech. It helps them with so many things on so many levels to be able to save these anterior teeth. And posterior teeth, the demands for aesthetics that you see in your adult practice, they are coming on just as strong in the pediatric practice, and parents are coming and they are asking for white fillings. And to do very well, to do a white filling on too large of a carious lesion, you're asking for failure. We needed to have an option to do full coverage for these kids, and so these Zirconia prefabricated crowns that we're using are a fantastic option. And I in my practice, I've used all of the ones that are available in the United States and Canada, and they're a great thing to use. Definitely.
These guys practice all alone. My whole motto is that with Dental Town, no one has to practice alone. Talk about name brands, the technique. What do you cement it with? Do you cement? Are
Absolutely.
you bonding?
I'm glad you asked. I really am. So as I said, I've used all of the ones that are available. We've got about 4 brands that are available in North America, but by far the ones that I've used farthest and widest and done, I can't even tell you how many thousands I've done of these, are the New Smile crowns. So New Smile is a company.
It's called New Smile Crown?
Yeah.
Is that the website newsmile.com?
It's NUSMILE.
NUSMILE.
You got it. Newsmile.com. And that's out of Houston.
Ryan, come over here, and while she's talking, see if you can pull up newsmile.com. Newsmile.com out of Houston.
Yeah, so it's out of Houston. So it's an American company. And they really have a fantastic product. In my opinion, it's a superior product, both functionally and aesthetically.
And these are zirconium.
These are zirconia. So it's a new paradigm shift for us as pediatric practicing pediatric dentistry, because we now need to learn how to use this material. We're used to using stainless steel crowns, and by no means are those out of the picture. We're still doing a ton of stainless steel crowns. I heard you refer to them as chrome steel crowns. Yeah, that's what we would call them in Canada, are stainless steel crowns. Still need to do a ton of those, but the whole cementation is completely different when we're talking zirconia and we're talking stainless steel, because now we're talking zirconia, we start thinking about things like contamination. We don't want to have any blood contamination. We don't have any saliva contamination when we're cementing these, because that your cements are not going to cement properly if you've got blood and saliva. And blood and saliva is a fact of life in pediatric dentistry. We're not cutting the crown and sending the patient away and bringing it back and cementing it when that tissue is healed. We're cutting the crown and we're cementing it within a minute of cutting it and finishing that prep. So there's blood, there's saliva, and we need to start thinking about that.
NewSmileCrowns.com. And is this company started by like a pediatric dentist, or?
No. The founder of the company, the founder and CEO, Diane Johnson, is actually a lab technician, and she had seen the need from one of her friends, was asking for an aesthetic crown. So the way she started this company was to answer that need for that aesthetic crown for the
What's her
pediatric
name?
Dentist, Diane Johnson.
Do you know her?
I do know her. So she started the company to
in Houston
to meet the demand that we needed for aesthetic crowns. It didn't start off with zirconia crowns for her. I'll let her tell you the story. But the first generation of aesthetic crowns for pediatrics was a pre-veneered stainless steel crown. I'm sure you've seen them. It's a stainless steel crown with a white facing. So that was the first generation, and it was a good option. It was a great option for anteriors, posteriors as well. But the zirconia has far surpassed, in my opinion, the aesthetics of these pre-veneered stainless steel crowns, and we've got durability that is fantastic with them. So I've been placing them, and like I said, the majority of the ones that I'm placing are new smiles.
So the homies want to know what's the price of like a standard chrome steel crown, and what's the price of a new smile zirconium crown?
So my prices are probably going to be a little off because I'm telling you in Canadian dollars. But I'll pay somewhere around $6 per stainless steel crown. The zirconia crowns are closer to between $18 to $20, and you can do your conversion like we said.
So 12 for chrome steel crown and 20 probably for zirconium. Is that what you said?
No,
or
I think it's less. Six for
and then 12 to 20.
Yeah. So and then 18 to 20 for a zirconia crown. So you're definitely.
But how
paying
much
the cost.
is the price for a chrome steel?
The procedure then is much much higher. You definitely gain your investment.
So how much do you
again.
charge for a chrome steel crown or a crown?
Again, it's going to depend on where you are. So if we're in Manitoba, it's going to be different than when we're in Alberta or if we're in Ontario. So
but what would the range be?
You're probably looking at charging maybe somewhere around $80 more for a zirconia crown than you would, like this would be my charge to the patient, than I would for a stainless steel crown. So you're looking at somewhere in $100 and something range for a stainless steel crown, and then you're somewhere $200 and something for a zirconia crown. So about an $80 span.
And I also think a lot of parents have guilt that they did something wrong when their kid has a bunch of silver crowns in their teeth. It's almost like I think that's why women don't care if there's gold all over their body, but they don't want a gold crown.
Right.
Because a gold earring doesn't say I did something wrong, but a gold tooth says I had a cavity and it broke.
And it's okay if the parents look in the kid's mouth and there's a bunch of little brown or green teeth. That's okay, but not okay if they look and there's a bunch of stainless steel. Then they want to have white teeth. They want their kids to have white teeth, and they'll seek it out. They will.
I also noticed that moms will buy braces on their children for $5,000 long before they'd get a $5,000 facelift or boob job or tummy tuck. So I always see mom 9 times out of 10 the self-sacrificing for the child.
Yeah.
So she's going to buy cosmetic dentistry for a child 10 times before she'd buy it for grandfather.
Yeah.
And herself.
Yeah, it's true. And the cost differential that we're looking at between a stainless steel crown and a zirconia crown for a kid is not that big. It's not like we're asking thousands of dollars.
So what do you cement them with?
So there's a couple things that we can cement them with. We can cement them with Biocem, which is an ionic resin cement. That's sold by New Smile as well.
An ionic resin?
Ionic resin cement. So it's got ions that flow through the resin as well. It's going to release calcium phosphate and all kinds of great things for the tooth. And now, like I said, we need to be careful that we're not contaminating our crowns, which is an issue with our resin cements. So to get around that, what New Smile has done is they've developed a pink try-in crown. So we don't actually take the crown that we're going to cement until it's time to cement it. We do all of our prep and our try-ins with these pink try-in crowns. We can contaminate them as much as we want, and then we re-sterilize them. When it comes time to cement, we take a fresh crown from our box and we cement it with that. So Biocem is one option that's been great. Another option is Ceramir from Doxa. We don't need to worry at all.
Doxa? Mm-hmm. What's Doxa?
Doxa, D-O-X-A.
D-O-X-A.
D-O-X-A. So that's a company out of, and I hope I'm going to get this right, I think it's out of Sweden. And so that's a calcium aluminate cement. And Doxa has developed this cement. We don't need to worry about contamination because it works in a different way than our resin cements. So the Ceramir has been a great thing to cement these zirconia crowns with. And then our final option is just a resin-modified glass ionomer cement, which we use far and wide in pediatric dentistry.
Doxa.com.
Yep.
So do you know the person there too?
I have contacts for you. I'll put you in touch.
Yeah, send me them. So in Ceramir US, who is that?
So that's Doxa. It's sold by, they had it at the show today. Bisco's selling it in Canada for us.
Really?
Yeah.
But you know someone there that you get me in contact with?
I know them all.
You know them all? Well, yeah. Anybody you're talking about, let's talk to them about it. So let's get back to some real questions. When I'm doing a crown on an adult, I want to last for a long time.
Right.
How long is the when you do your average? Well, I keep saying chrome steel crown, but these aren't chrome steel. What is it? Just
Zirconia.
a crown?
Zirconia crowns.
But if you take out the stainless steel,
yeah.
or the Zirconium
Prefabricated crown.
prefabricated
You wanna call
crown,
them that? For sure.
how old is the average child when they get a prefabricated crown, and how old are they going to be when that tooth falls out anyway? I
Yeah.
mean, are we looking at a
Well-
window of about 4 years?
Yes or no. So it depends what we're restoring. Depends how old the kid is. We're doing
Aren't they mostly
anterior teeth.
A and B?
Yeah. So A and B in the United States are your
Canada.
first and second molars. Okay. So we have sort of two scenarios. Let's talk about our anterior teeth first. So
And
let's
is that
say
going to be mostly baby bottle tooth decay?
yeah. Yeah,
All the time?
Yeah, mostly apple juice. Neglect, the whole gamut of dental faux pas, and people get cavities. Cavities are that's a fact of, unfortunately, of life, and people aren't going to start kissing their babies either.
Right, I know.
So,
I know.
okay, so let's say we're restoring anterior teeth. So we'd see traditionally, I guess, lateral to lateral. Okay, I'm talking a universal way that
Four
that I can say.
upper
Four
incisors.
anteriors, yeah. And so when kids come with decay, usually we'll see them come around the age of 2 with that. Sometimes we see them a fair bit earlier with anterior decay, but at the latest, we'll start restoring these teeth around the age of 2, give or take. So we start exfoliating our central incisors about the age of 6, and then the laterals will start to go maybe it's the age of 7 or 8. So we got a lifespan of those anteriors of, say, 4 to 5 years is what we want these zirconia crowns to last. Now, keep in mind, these are kids. They are not going to be careful with their teeth. They're breaking off Lego. They're biting into apples. There's corn on the cob. We are demanding a lot.
Their brother's finger.
Absolutely. We're demanding a lot from our restorations. We're demanding a lot from our cement. The kids are falling and they're hitting themselves. So this is the lifespan of the anterior teeth. Posterior teeth, there's much more variable. By the time we get to the amount of decay where we need to place full coverage on that tooth, sometimes we have these kids come in at the age of 2. Sometimes they're not in until 5, 6 with that amount of decay. Sometimes it's a failed restoration. So we'll exfoliate our first primary molar around the age of 11 years and second primary molar around the age of 12 years. So, take your pick. When are you restoring them? How long do you want them to last for? And then again, in the posterior, we got all kinds of issues to deal with. Lots of kids are bruxing and grinding the heck out of their restorations. So that has to hold up to that force as well.
So I wish you this is so informative, and you're so on top of this game. I put up 350 one-hour courses on Dentaltown. They've been viewed over 500,000 times. Do you ever give this lecture in like a slide or PowerPoint?
I give this lecture all the time.
Is there any way I could beg you to put this on an online course on Dentaltown?
It depends what do you want? Do you want us to just do talk about zirconia? There's resin infiltration that's hot and coming.
I'd
There's
love to have it all.
Bioactivity. Of course,
I'd love to have it all.
I'll go out and do courses, lectures, hands-on, 10, 12 times a year. I have a couple of webinars up there online that are powered by Viva for different companies. So I've done been there, done that. I can develop something if you want to have a specific topic in an hour. I pretty much know what I can.
It could be longer. I think learning how to treat children is very difficult. The most viewed course we ever put up was actually a pediatric dentistry course by Josh Wren.
Yeah.
And we asked some of the users, why this course? And they just sit there and said, I can learn about endo and perio from a dozen different places, but there's not many people teaching pediatric dentistry.
No, there isn't a lot of pediatric
And it was
dentistry.
our most viewed course is pediatric dentistry by Josh Wren. So would you be willing to teach some more?
We can talk about it.
And I don't know anybody. I really, in my backyard, all my friends, none of my friends in Ahwatukee are doing white zirconium on children. I'm not doing them.
No. It's something that the pediatric dentists have really embraced. It is slower to take
they haven't
with
really
the general.
embraced them?
They have really embraced.
Oh, they have really embraced
slower with the general dentists. But I can tell you, when I go and I teach hands-on courses, hands-on workshops, and I teach mostly general dentists. There's always, one or two pediatric dentists that come in, because my title for my course is Pediatric Dentistry for the General Dentist. And it's the general dentists that can do the zirconia preparations, with their eyes closed, because they're used to doing a traditional prep. And when we're doing a zirconia prep, we're taking more tooth structure than we do for a stainless steel crown. You're not cutting with that little, inverted pear that we cut with. We're cutting with diamonds, and the restoration procedure seems to be something that the general dentist can catch on to really, really quickly. But yet, the majority, I think, and you can ask this to the CEO of the New Smile company, the majority of their sales goes out to pediatric dentists for sure. There's a whole other factor that goes into this, in that general dentists are often shy to be able to treat the patient with the behavior management that takes place. And you're doing anterior crowns. We're doing these on 2-year-olds and 3-year-olds. They're not the easiest people in the world to get to sit still for us. We got to be quick, we got to be efficient, we got to be calm, and all the rest of it, whole laundry list of what we need to be. So there's more that mixes into it than just the procedure.
So let's talk about a couple more things. So give us some verbal skills. I'm the dad, and I want to come back with my child.
Yep.
Is that good or bad?
You want to come back into the room with your child?
Yeah, my kid's 3. He
Yep.
needs to come in there. He's crying. He's got a toothache. Do you want me in the... And I say, I want to come back with my child.
Yeah, and there's a lot of strong opinions both ways on this. My stance, the way that I practice my dentistry, is the parents can be back there with the kids. If I have a kid that I know is going to play on the empathy of the parent, and that is going to stop me from getting the procedure completed, I will tell the parent, look, it's best for little Hayden, Caden, Braden, if you're down in the waiting room waiting for us to finish. We're going to get the job done a lot faster, and he's going to cooperate with me better. We have that conversation not the time that we're about to go into the room with Hayden, Braden, Caden, but when we are discussing this needs to be done and this is how we're going to get it done. But for the most part, parents come back to the room with me, and that's fine. My routine with the kids is the same whether the parent is there or whether the parent is not there. If I need somebody to hold a hand, I'm going to have the dad hold the kid's hand. I want my assistant to be able to pass me instruments, not to be holding a kid's hand. And so we have the parent in there. I use that opportunity to teach the parent of what I'm doing and what's going to happen, why we're doing this, how we can prevent it. There's a whole realm that goes on. And I want that parent to be in there seeing how I am with that kid. So I want the parent to know that, nothing bad has happened to your kid, because sometimes you have a kid in your operatory, you send the kid back out to the parent, and everything had been fine in the operatory, and the kid starts bawling. And what's the mother or father thinking? What happened to you up there? What did they do to you? And, really, what did we do? Just what we always do to treat our kids the best that we can.
So another, I like to ask all the uncomfortable conversations. Papoose board. Is there still a place for papoose board, or is that cruel and unusual punishment?
So papoose boards, actually, that's politically incorrect. We are supposed to be calling them immobilization devices.
So papoose is...
that's an immobilization device.
So that's politically incorrect?
Apparently it is. Somebody, another pediatric dentist had said that to me, so we call them immobilization devices. I don't like to practice like that. I will use my papoose board in an emergency situation. So if I have a kid that's come in with trauma and we need to get something done quickly and safely, if I have a kid that absolutely cannot be treated in any other way, I don't want to be doing anything that is long and involved with a papoose board. I wouldn't want to be treated that way. So we use it when we have to. We pull the thing out maybe a handful of times a year. And
every other month?
Yeah, maybe.
And well, it's tough because a lot of times if it's not papoose board, it's going to be in the hospital general sedation.
Yeah.
So in your practice, how often are you taking a kid to general sedation. Do you do that in the dental office, or do you go to the hospital?
I have a surgical center that I go to, so I work with an anesthetist. I have the anesthetist sedate the child under general anesthetic. So I go in, I take in 10, 15 kids a month, that's my average per
on one
year.
day, or
No. It's over. That's over a few days. I'm
so 10 to 15 kids a month. So you go to a general surgical center,
Yeah.
where a board certified anesthetologist provides anesthesia.
Yes, yeah. I do that. I do that because I never wanted to, first of all, I don't think that sedation, unless it's a deep sedation on a child, works. I think the kid has to be pretty deeply sedated if they're an uncooperative child. I never wanted to be in a situation where I had to resuscitate a kid. I'm a dentist. No. I am not wanting to have a kid in that situation in my office, so I just don't do it. And I never have, and I never will. So if a parent wants some sedation that's not a general anesthetic, and I can't do what I need to do with just local anesthetic and the sweetness of my voice, then they can go somewhere where somebody else can
dentists
help them.
always want to shelter their own, and I'm the first guy to throw the dentist under the bridge, because I call it the way I see it. And in all the hospitals in the United States, you're not legally allowed to do the anesthesia and the procedure.
Correct.
A cardiovascular surgeon can't be running your IV and doing your bypass.
Right.
And it was the British who showed me the first time 10 years ago that when the physician does the anesthesia and the procedure, their death rates are higher. And they were talking about their own oral surgeons.
Yeah.
And in the United States, the oral surgeons have twice the mortality rate because they do their own IVs. And the bottom line is, the question is real simple. How many Americans have to die before the dentists adopt the same standard of care that the physicians adopted 50 years ago, that one person does the anesthesia, one person does the procedure, and the person doing the anesthesia, just that's all they do. They're staring at the monitors, and they get it done about with half the mortality of when the doctor's trying to do both things. Do you agree with that statement, or disagree?
I do agree with you. And until it's regulated in your particular jurisdiction, you need to be responsible and true to your
And I've
patient.
also heard this many times. When you're a doctor and you do your anesthesia and someone dies, and they take you to trial, and they bring in a board-certified anesthesiologist to cross-examine everything you know about anesthesiology, that they make you look like an idiot on trial. I mean, you're a dentist. You do root canals. You do pediatric dentistry. You can't hang with an emergency room anesthesiologist on trial.
Yeah.
And then there's a dead kid over there. So yeah.
We don't
I think
that.
it's one of the most underutilized things in dentistry. I mean, when calls come in, I would say about half the calls are saying, well, how much is it? How much does it cost? Is my insurance?
Absolutely.
Money's half. But once you leave money, then it goes to, well, am I going to get a shot? Is it going to hurt? Can you knock me out? Can you put me to sleep? And then all the dentists, the only thing they heard was same day crown. I just want my crown in the same. It's like, I hear that like once every 6 months. And everything else is, how much does it cost? How much is it going to hurt? Okay, another controversial question. Some of these young kids come out of school and they go work with some old fart, and he's using for a pulpotomy, he's using formicresol, Crescidin.
Yeah.
And these young kids are on Dental Town saying, "Hey, isn't that carcinogenic? Is that a bad?" What would you say to some old guy who's using formicresol, Crescidin? Are there any other ones from back in the day?
Those are basically the.
So
two.
is that carcinogenic? Is that cancer causing? Do you use it?
It depends who you ask. So ferric sulfate, which I believe is what you're talking about, Crescidin that would be a brand name.
Does that sound right? No, Crescidin was some chemical 30 years ago.
Okay,
something you smell and it's like
awful.
But it was the pulpotomy.
It was the pulpotomy agent
stuff.
Okay. Well, maybe Crescidin. Maybe it's the cresol.
Cresol.
So that's the same thing as formicresol.
Yeah. Okay. So I think it was a name brand of formicresol. You're right. Crescidin was
so let's talk
cresol.
about formicresol. Yeah, the studies have come out and said that it's a carcinogen, and in 2011, the American Food and Drug Administration put it on the list of known carcinogens.
2011.
2011, I believe, is the date. And if I'm wrong on that, I'll correct myself. And
I did not know that.
I think that was it. So known list, not banned yet. And it is banned in some states. Some states' regulatory boards have gone ahead and banned the material from being used, so you cannot use formicresol in certain states. Then there was a whole lot of other literature that came out from some very good sources that had gone and done what's the word I'm looking for? They've done plasma tests on these kids that have had formicresol pulpotomies and blood testing, finding out that, in fact, there is not any formicresol running through their veins. So, you have to take those both things as knowledge, but know that there are better up-and-coming materials and materials that we've been using for a long time that have been doing that job without any fact of using a carcinogen or a known carcinogen, whether it is or whether it's not. I'm not educated enough to answer that question, but we now want to use MTA as a pulpotomy material, which was a problem in the past because MTA was very expensive, cost prohibitive for doing these procedures. Formicresol's pennies, and you can do the procedure, you can do it fast, you can go ahead and put your IRM in there and you can be done. So then in the last recent years, there have been a couple of things that have come out. So biodentine has come out from Septodont. So biodentine we can use for pulpotomy procedures. But it has its limitations as well. It comes in a capsule, which some people questionable, and a 12-minute set time. We get around that with a procedure and a technique that I use that we don't have to wait that 12 minutes. But since then, Neo-MTA has come on the market, and Neo-MTA has an even shorter set time, and it's less expensive yet. So, whichever product you're comfortable using, this is what we use for our pulpotomies. And then those have a higher success rate using MTA or the biodentine, which is an MTA-like material, than our formicresol ever did. So that I believe is what we're looking at as our standard of care for pulpotomies now, is to use an MTA or an MTA-like material.
And MTA, that's out of Southern California. What was that? It was a pool cement or what?
Yeah, so that was one product. The Neo MTA, I'm not sure where it's manufactured, but it's sold also by New Smile. So they've got the whole pulpotomy, crown, cementation of the crown. They've got those steps all nicely packaged together with their products. So that's where you can get that.
So I want to help you with some more verbiage, because you do this. This is all you do.
Yeah. And
I'd say most of us kids might be only 10%, 15% of what we're doing. I'm just gonna be the dad. Why do I need to fix this? Because it's gonna fall out anyway.
Yeah.
I mean, and I might just waste my money. I mean, come on.
And people ask that a lot, and that's an attitude that we see.
So what do you say to me?
You
hear that in Canada too?
Okay. Well, we hear everything that you hear. We're just maybe a little later date. You're always more advanced in timing than we are, but we hear it all. So the answer is we need these teeth to function. We need to be able to chew, and we need to be able to grow. We need to be able to smile. You want to have a child that's pain-free. Decayed teeth, severely decayed teeth, don't exfoliate normally in a normal pattern. If we have root tips left behind, those root tips can stay behind for a long time. They can deflect the eruption of the permanent teeth. Do you want to walk around with a toothache in your mouth for 8 years? I don't think so. Why would you let your kid do that too? Now, every time they're swallowing, all of that decay, all of that crap going down, every time they're swallowing, all that bacteria and all that acid, it's not a good thing. So we want to help our kids. We want to treat our kids. Don't leave them. Even if they're in there for a year, you want to treat these carious lesions.
Okay, I know my job is to estimate what these homies are thinking they wish they could ask you, and I know they're wondering, do you ever do amalgam, or you only posterior composite? What are your thoughts on amalgam versus composite?
So
on baby teeth?
Yeah, I mean, amalgam is still widely used. I don't use it in my practice. What I use instead, if I have a situation where I can't keep things dry and use my composite restorations, so I'll use glass ionomer, which is a nice hydrophilic material, very forgiving. I can use it in a wet environment, and I use it for those cases that I can't keep dry, whether it's from a kid.
And what glass ionomer do you use?
There's a couple out there that I use. I'll use the GC America product, so the Fuji 2LC or the Equia, which is a self-cure glass ionomer system, or I'll use the SDI products, which are called Riva Light Cure or Riva Self Cure. Those are the two main glass ionomers that I use, but you can't practice pediatric dentistry without them. They're strong. They are able to release fluoride. They are just an absolute must if you're doing any amount of pediatric dentistry.
Tell me this. I'm an American, but I'm only 100 miles from Mexico, so I might be more Mexican. You're up here in Canada. How come when you travel around the world, glass ionomer is huge in Japan, Australia, New Zealand,
Europe,
and a lot of the international data I look at, it's almost like American dentists use less glass ionomer per 1,000 units.
Yeah.
And Japan and Australia and New Zealand would be the most. Why do you think in a flat Earth where we all have the same iPhone and here, Sydney, Japan, why do you think there's such a huge variance in glass ionomer?
Yeah, what you say is exactly true. Glass ionomer is used much, much more widely abroad than it is in North America, and our material of choice seems to be composite, and it's a great material, and they're strong, and they're aesthetic, and they're better than they ever used to be, but they are not the best material on a kid that's full of spit. So we need to
explain that in detail. Why is it not the best material for a kid full of spit?
Composite is incredibly hydrophobic. We get moisture in there, contamination, and you're going to have a restoration that's going to fail. If we can do that same restoration with the glass ionomer, which is more forgiving, it requires water for that acid-base reaction of the glass ionomer, then we're going to have much more chance at a successful restoration. Plus, since the glass ionomer is going to release some ions, it's going to release some fluoride and help that demineralization around the margins, we're going to have a better chance of success. Because when we have a failed restoration in a kid, it's recurrent decay, it's residual decay, it's always around the margins. So there's studies that they've published. There's literature out there talking about how much more effective glass ionomer is in class 2 situations than composite, than amalgam as well. So why are we not using it as widely? I think it's an education thing. I think that we're used to the norm of using composites in our practice. We know how to use them. We know how to deal with them. We know how to apply them. Glass ionomers require some mixing. It's a different feel when you're putting it in. It's a bit of a learning curve.
But it's less technique sensitive.
It is.
It can handle some moisture contamination.
Yes.
And it has antibacterial, bacterial static properties.
Yep.
And so all of these posterior composites, which the dentists say last longer than amalgams because they're insane when they say something like that. Because, when you say a composite lasts longer than amalgam, do you really go to Kentucky Fried Chicken and believe that your plastic fork at KFC lasts longer than the metal fork at home in your kitchen? If you believe that.
I like that, but it looks better. It's prettier.
I don't even know where to start with that. So we know the metal fork at home lasts longer than the plastic fork at KFC. We know the fillings fail because they're technically put in wrong, and the composite is more technique sensitive than the glass ionomer.
Right.
And the amalgam almost has no technique.
Right.
You can
Yeah.
So what percent of your tooth colored restorations in pediatric dentistry are
glass ionomer?
resin composite versus glass ionomer?
I still think that we're probably doing maybe 20% glass ionomer to 80% composite, never minding any of our full coverage stuff. But the reason is, you got to remember too that glass ionomer is not as strong as the composite is. So if we have a deep restoration, the glass ionomers tend to be more brittle. So there is a higher chance of a glass ionomer breaking than a composite breaking. So you got to kind of weigh the balance. So I'll use my glass ionomers in situations situations where I can't keep things dry. I use them in situations where I'm looking at it as a very short period of time. I'm using it in situations where I'm buying time. If I've got an average to large size lesion, well, maybe we'll do a sandwich, take advantage of both of the properties that we want from the composite and the glass ionomer, or maybe I'll go full composite. So it depends.
I noticed the only people who don't understand what a sandwich is an American. I mean, that's a common term in Asia, but explain what do you mean by a sandwich?
So if we're using a sandwich, what we're doing is we're layering our materials basically, and we're taking advantage of the properties of each material. So at the bottom of the sandwich, so at the gingival floor of the lesion, let's call it the deepest most part, we would be using something like a glass ionomer that could give its antibacterial properties. That's going to be kinder to the tooth than a composite would be. So that would be layer one, and then we would use the composite as a layer on top of that in order to take advantage of the strength of the composite and as well as the aesthetics of the composite. So we would layer things. There's all kinds of different layers. What I'll do with my glass ionomers too in certain situations is I'll layer glass ionomer and then I'll put a layer of flowable over top of it. It all depends on the location of the lesion. It depends on the occlusal forces. It depends on the aesthetics. How long do I want that restoration to last for? How long can my kid sit still for? It's all based on all of that whole mix all put together.
I'm going to switch to completely different subjects. A lot of times we dentists are stressed. A baby tooth's got to come out.
Yep.
What are you thinking when I got to do a space maintainer or not?
Right.
Do you have any quick rules of thumb or any thoughts?
Sure.
Can we go down that direction?
Space maintainers in general, we look at space maintainers for posterior teeth, and there are a couple of cases where we've lost space anteriorly. But in general, a space maintainer for a posterior tooth, if I've got a second primary molar that's lost, and my 6-year molar is in or not, I want to have a space maintainer in there because I don't want that 6-year molar to drift into the space of the second primary molar. The first primary molar is a bit of a different story, and there's a little bit of finesse that comes with it too. If we have our 6-year molars and they're in complete occlusion, we got a nice tight occlusion, the literature is telling us if we got that first primary molar is gone prematurely, second primary molar is there, and the 6 is there, maybe there's not so much need for a space maintainer. So we'll do a unilateral space maintainer if the need is there, or a distal shoe. If we have bilateral space loss, we'll do a Nance appliance or a lower lingual holding arch, provided that we have the permanent anteriors erupted. So it's kind of a hard question to answer in a few sentences, but in the end, I'd always rather err on the side of caution, and even if we have a space maintainer that's in there for a matter of months instead of years, I would rather do that than have to explain to the parent why now we have to make a distalizing appliance that's going to cost them several $100s versus the space maintainer that would have been $100 and change. And we've got some really good products out there too that are chairside space maintainers. So we've got some from Space Maintainers Lab, I believe it's called, out in California, where it's a chairside band and loop that you put together and you can cement it immediately after the extraction. De Novo has the same type of product where you can go ahead and put the band and the loop and fit it at the time of the extraction. And if you're doing a distal shoe, that's often the way that you need to go, because you don't have the luxury of having that patient come back and you don't want to re-anesthetize and the whole thing.
You are an amazing Heidi. Not Heidi.
Carla.
Carla. Yeah, I was like, the last podcast was Heidi Alpha. Carla, you are an amazing wealth of knowledge. I would give anything for you to do an online C course. And also, we've been Dental Town. There's a Indian Reservation casino right by our place, Talking Sticks Resort Casino, where we've been putting on hands-on lectures.
Yeah.
I would love for you to put on some didactic courses on Dental Town,
Sure.
and then build demand for coming down to Phoenix and doing some hands-on, because I think
Yeah.
a lot of dentists that are hearing this on your podcast would want to see more in the slides and the presentations, and probably want to go. You do hands-on courses.
I do hands-on courses.
And what do you
also
teach in your hands-on courses?
Yeah, it depends what you want to learn. There's always a demand for aesthetic prefabricated restorations. So zirconia is pretty much a given in all of them. I'll go through a lot of the bioactive materials, so things like the shofu, the Jimers, the Activa products. I'll do we'll do our basic composite fillings, and I love to be able to include glass ionomers in there as well. Whatever the demand may be, however long the course is. I've done a day course, I've done 2-day courses, I've done half-day courses, all hands-on. So
one of my homies wanted you to speak at their dental society, or contact you. How did they get a hold of you?
Yeah, so they can get hold of me through my personal email, I guess is probably the best way. It's Dr. Cohn at shaw.ca. Remember, there's
Dr. Cohn, C-O-H-N.
C-O-H-N at shaw, SHAW.ca. Remember, we're Canadian.
Yeah, and I see that .shaw. I see .shaw a lot for Canadians. What is Shaw? Is that
just our carrier? One of our carriers.
Is that like an internet cable TV?
Yeah, so it's like saying,
Cox?
Yes, exactly. Exactly.
So Shaw, S-H-A-W.
SHAW.ca.
And then it's .ca for Canada.
Yeah, so that's probably the best contact. Then you're for sure to get hold of me and not go through any.
So you were born in Winnipeg, Manitoba. So does that mean your favorite sport is hockey?
No, absolutely not.
What's your favorite sport?
I don't know. I don't think I have a favorite sport.
Right?
We do other things.
I want my last question to be something totally off the record, but I get this question a lot, and I'm embarrassed to ask it because you're a woman, I'm a man, but a lot of we've seen a lot of changes when there's a lot more women dentists now than when you got out of school.
Yes.
Would you agree?
Yeah. Oh, yeah.
Would you consider yourself almost a woman pioneer? I mean, were there a lot less women in your?
There were a lot less women.
How many women were in your class when you were in dentistry?
I was probably, we were 20% of our class. So
okay.
Yeah, it was a small class. We were like 25 people, period. And I don't know. I don't think I would say pioneer, because I think that the women that were 10 years, 20 years early were more.
I want you to ask this. Sometimes young little girls in dental school say, what advice do you have? I get this all the time. They say, my number one complaint on my podcast is that when I interview a dentist, it's a man.
Yeah.
When I interview a woman, it's a dental consultant.
Yeah.
And, and they say they tell me that's sexist, and it's like, it's not sexist.
That's the way it
I'm
is.
trying really hard. So I call you guys unicorns that, but they want to hear, young girls in dental school want to hear from, I don't want to say older women, but
don't do that.
But, women who have been out a couple decades.
Okay.
So I guess this is our question. The main complaint I get is that these young girls get out of school and they say, I went and worked for Henry.
Yeah.
And I watched how he managed.
Yeah.
And I worked for him for a year or two. And then I bought the practice for $500,000. And now I say the same damn thing Henry says. And those girls don't obey me like they obeyed Henry.
Yeah.
And so they say to me, so their question is, do women, since 98% of the employees in dentistry are women in healthcare, and in mining it's 99% men. In construction in America, it's 96% men. So in mining and agriculture and construction, it's all male employees. But in healthcare, it's pretty much all women. And young women dentists believe that if old man McGregor says it, the women jump, and then she buys the practice, says it, they don't jump. Do you think that's because she's a girl and old man McGregor was a man, or do you think that's her? Well, what advice would you give? So my advice would be,
I might get lynched.
So my advice is, what advice do you give to young women on how they can be leaders?
I think you become a leader by acting and practicing responsibly and ethically. And as corny as this may sound, but I think that problem comes in because those people don't have the respect of their staff. I think if their staff sees them acting on a daily basis and a personal interaction with ethics and respect and strength, then they will earn that respect. I truly believe that. I don't think that it's a man-woman boss thing.
I want to say something that I have no credentials to say, but I want you to give some firm boundaries, because I think women cross the line with employees of being too friendly, too close than boys. I think one of the reasons boys don't is because I can't go out with all the women in my office afterwards for drinks and
Yeah,
that
yeah,
when I
yeah.
got a wife with 4 kids at home.
Yeah.
So I had natural barriers to I'm not doing that. But I look back and think that helped me lead them more.
Yeah.
Then I see some of these young girls going to happy hour with their staff and doing shots and tequila and getting drunk and being crazy. And the next morning, they're supposed to be your sergeant.
Right.
So can you lay any hard rules? How friendly can you be with your staff and still lead them? And what lines do you draw to say, no, I'm not your friend. I'm still your boss.
Yeah, that's a really hard line to draw, and it's true. We do
Is
have
there a
a
line?
personal relationship. I think there has to be a line, and I think that probably is different for each person, each individual. How you gotta keep that in mind. Exactly what you said. You're going to work the next day, and you're the one leading the group. You keep in mind what you do the night before, wherever it is that you're going.
I mean, how can you do Jello shots with Amy at night and the next day write her up for being 5 minutes late?
Yeah.
I mean, you know what I mean?
It is a hard line to cross.
It's blurry.
And I think that, I see it not necessarily in the dental world, but in other worlds, men do it too. They have, they go out with their buddies that they're their employees, and then the next day they have the same difficulty. So, yeah, you need to be cognizant of what it is that you need to achieve, and there's nothing wrong with being friends with your employees, but as you said, you also need to lead the team. So,
well, I think, Carl, I think you're amazing. I think I really do. And you're with the Catapult group, and that is nothing. That Lou Graham, and by the way, Lou Graham is my favorite singer. I gotta play Lou Graham. I hope he hears this. But Lou Graham, as you know, sang my favorite song. What is his favorite song? Lou Graham. Ryan, can you get this on the deal? Can you hear it? Now this is Lou Graham, Midnight Blue. Now, is this the same Lou Graham who started Catapult Dental? What is it called? Catapult Dental Consulting?
It's called Catapult Elite. And we're
is that him
is
right
it,
there?
Is it the same guy? It's kind of hard to tell. It might be. I'll have to leave that one to your imagination. He started a group of friends. Really, is how it started. And we all go out and we do continuing education. We'll do evaluations for products. Companies will come to us and ask us to evaluate a product and for our input. So it's a really cool group of dental keeners, and I'm always a little surprised that they let me join them. I don't know.
And tell us tell them what is that website?
Catapultelite.com.
Catapult.
So catapultelite.com will have all of the speakers' bios. They will have courses that we teach and what Catapult can do to bring a speaker to your group. So that's another source if you don't want to email me personally, to go to that website, because that will have contact information on how to get to our public relations people that book us our
and name some of the speakers on that group.
Oh, so we got to first and foremost say Paresh Shah, because he's
right here in Manitoba. I did
yeah.
a podcast with Paresh.
Yeah, he's
on,
a very awesome guy.
Complete dentistry.
If you want to make sure that you're going the right places, hang out with the right people, and Paresh is the right people. Who else is in there? Doug Lambert, Ron Kaminer, Gary Rads, Bob Lowe, Brian Novi. Lots and lots of great speakers that have been up and coming. John Kamisi going to come to Manitoba in January. He's a very brave man. He's going to come and speak to us about
We did a podcast with him too, and he's a big pulp dent lover fan.
Yeah,
and the reason I have a mutual attraction with him is because we both like silver fillings that can kind of retard. I mean, I feel like dentists want to talk about they're engineers, they're civil engineers that want to build a building. And I always didn't see dentistry as an engineering feat. I always thought it as a biology problem, that we're getting attacked by Streptococcus mutans that eats teeth. I mean, it's like, I'm from Kansas. The problem with the barns was not was termites. It
Right.
wasn't anything else. It wasn't the nails. It wasn't the wood. You know, the barn didn't come down because we used the wrong wood. And it seems like the dentists don't treat dentistry as a biological.
Yeah.
And so me and him, we like fillings that kind of retard
Yeah.
bacteria growth.
Yeah, absolutely.
And all my peers just don't want to talk about wear rates and bonding strengths and
Yeah.
flexural strength. It's like, are you building a bridge over a river? Because if you're building something in this mouth that has 1 billion bacteria, virus, and fungus per cc,
Yeah.
we're in different language. And I think the pulp dents are the future companies. And
Yeah, absolutely. You know, there's a lot of
and
bioactive
Fuji.
materials.
I mean, you know, like Fuji for pediatric dentistry.
You know, glass ionomer, maybe that was the first bioactive material that we
Absolutely.
had. So, you know, there's that, and there's shofu products and the biosem, and you know, even our MTAs and the biodentines, they're all bioactive.
And every ingredient of an amalgam is antibacterial.
Absolutely.
Mercury, silver, zinc, copper, tin. Every one of those is an antibacterial, and we replace those with inert plastics.
Absolutely. Yeah. So we got to.
But hey, I hope to see you put up some courses on Dental Town. I think that'd be great. If you ever want to do a hands-on course in Phoenix, Arizona, all you got to do is tell me the date and the time, because we put these on at the Talking Sticks Casino. And what's amazing about Phoenix is people don't have to travel. There's actually 3,800 dentists in the metro.
Wow.
I mean, that's like a country.
Isn't that more than Canada?
No, Canada has more than that, but it is a small country. I mean, there are many countries that don't have 3,800 dentists, and we got 3,800 dentists in Phoenix.
Yeah. Awesome.
But Carla, thank you so much for your time.
My pleasure. Thank you.
And thanks for fixing me on those people, because I would like to tag. If you want me to do 5 minutes on Skype, tag with like the founder of New Smile or Doxa or any of these things.
For sure. Yeah, no, they'll do it.
I would love to do it.
They'll do it for sure.
And tell your Catapult Elite colleagues that I've talked to you. I've talked to Presh. Love to talk to Lou Graham. Like to have him sing that song Midnight Blue live on. But thank you so much for your time.
Thank you.
All right.
My pleasure.